Welcome to the Dr. Raj podcast with Dr. Raj Dasgupta, a show all about educating patients, students, and aspiring doctors about better patient care. Dr. Raj is a quadruple board-certified physician and associate professor at the University of Southern California. He was a co-host of the TNT series Chasing the Cure with Ann Curry, as well as a regular on the TV show The Doctors. And now, here's our show.
Hi, and welcome to the Dr. Raj Show. And of course, the Dr. Raj Show is not only about how much geeky medical knowledge do you have, but it's about being yourself. It's just about being a nice person. It's about talking about wellness and health and people who can influence others to just be a better person, being a better you every day. And today, I always get to brag that because it is the Dr. Raj Show, I could bring my friends and really cool colleagues that I know are just awesome. And I played that card again. It's kind of like the theme of me, you know? And so we have an amazing cardiothoracic interventionalist, radiologist who is super good friend of mine. It's Dr. Lin. And before we do introductions, you know, the routine, everyone, got to read her bio. So Dr. Lin is an assistant professor of clinical radiology at the Keck School of Medicine of USC. Go Trojans. She is the director of the USC Lung Cancer Screening Program and the associate section chief of Cardiothoracic Imaging. She works at Keck Hospital of USC, LA County Hospital of USC, and Norris Cancer Center of USC. Dr. Lin grew up in Rochester, Minnesota, then Scottsdale, Arizona, and she earned her BA Magna Cum Laude, such a bragger, I swear, from Bowdoin College, which I got to tell you is a really super hard college to get into. It goes under the radar. Her medical degree from Jefferson Medical College in Philadelphia, and completed her Diagnostic Radiology Residency in 2013 at Kaiser Permanente Los Angeles, and completed her fellowship in Cardiothoracic Imaging and Intervention at USC in 2014. She then joined the USC Faculty Department of Radiology. Her clinical and research interests include lung cancer screening, pulmonary infections, and vascular imaging. In addition to interpreting chest X-ray, CTs, and MRIs, she performs thoracic interventions, including percutaneous CT-guided biopsies. Teaching is one of her passions, and she teaches cardiothoracic fellows, radiology residents, medical students in both the clinical and lecture settings. Dr. Lin has presented multiple lectures, educational exhibits, posters at multiple national meetings, and is the member of the Society of Thoracic Radiology, Radiological Society of North America, I'm going to pronounce this wrong, Rotengen, did I say that right?
Rankin-Ray.
Oh my God, everyone's all embarrassed. I screwed that one up. Rankin-Ray Society and the American Medical Women's Association. She has a passion for mentoring women physicians and is currently starting a women's leadership in medicine group within the USC Department of Radiology. And with that said, Dr. Lin, how are you?
Dr. Raj, thanks for having me. That was great.
I know, because you're my friend. I just know you're successful, but you don't realize until you read the CV. I'm like, wow. I don't give her enough credit sometimes. You know?
Some surprises in there.
So you know how this is going to be. I think that for the first half, I got some get to know you questions. I know you, I think, but I want my listeners to get to know you. So are you ready for some personal questions?
Yeah, that's great. I'm excited.
So it does seem when you're all over the place. You're in all over America. I mean, are you part of the witness protection program or something?
You know, yeah, when you were reading that, I got that same feeling. Well, I've lived a lot of places, and how it started is my father is actually a radiologist as well, a chest radiologist. Oh. And he did his training and worked at the Mayo Clinic in Rochester, Minnesota. So that's why I was born in Minnesota. And then in 1987, they built a Mayo Clinic in Scottsdale, Arizona. So then my parents decided they wanted to leave the Minnesota tundra and retire in someplace a bit warmer. So that's how we ended up in Scottsdale, Arizona.
So how old were you when you left when you left Minnesota? How old were
I
you?
was 10. I was 10. So I still, I liked the snow and playing in the snow.
Yeah.
I wasn't old enough. I had to worry about driving in it or anything like that.
Yeah.
So I really loved living in Minnesota, but then going to Arizona was just so great. I mean, there were swimming pools everywhere. And, it was great. So I feel lucky that I was able to live in both places. Living in the Midwest, the people are so great. So I'm glad I got that good base. And then I'm going to Arizona, it's a little bit more diverse, a larger city. So that was great too. So I'm glad I got to live in both places.
So no, I'd been to Minnesota for a conference or two, and where you live, was it close to Bloomington? Or
yes. No? Yeah, pretty close.
Was?
Yeah.
All right. So reason why I'm asking, because, people in Minnesota, don't be mad at me, but the thing I remember the most about going there is the Mall of America. Have you been to the Mall of America?
Oh yeah, you just go in circles and circles and circles and many floors.
Did you get lost? Did you get lost in the Mall of America?
I loved it. I mean, I was a kid when I was there, but yeah, you could definitely easily get lost.
Yeah, I'm scared to bring my kids there, because if they get lost, I may never find them. There's a map just to navigate through this mall. You know what I mean?
Mm-hmm. Yep.
So from there, it sounds like, Arizona, which is like you went from ice skating to like swimming pool in hot weather. So how long did you live in Arizona for?
So I moved there in 4th grade and I finished high school there. And then when I was looking at colleges, I have an older brother and sister who are also physicians, and they are about 7 and 8 years older than me. And they went to the small liberal arts college here, Pomona College here.
Okay, I know what that is. Yeah.
So I would visit them there as a kid, and I fell in love with the size and the type of school, small liberal arts, and it was beautiful. And I got to meet the students, some of their friends, and I just loved it. So when it was my turn to look for colleges, I knew I wanted something like that, a small liberal arts college. My high school in Arizona was a large public school of about 2,500 kids. So I had done the big school experience, and I wanted to check out a smaller college. And now that I had lived in the Midwest and also the West Coast, so I wanted to check out the East Coast. So, I mean, I'm a little embarrassed to say this, but really how I based my college search was U.S. News and World Report. I'm not kidding. I looked at the top 10 liberal arts schools that were on the East Coast and applied to all of them. And I ended up at Bowdoin College in Brunswick, Maine. And wow, I am so glad I did. I loved it. What a great experience. I had never been to the East Coast before. And, a lot of the students at Bowdoin are from Boston. So I had a lot of friends from Boston. So I got to go to that city a lot: Boston, Rhode Island, Vermont, New Hampshire, Connecticut. So then I got to explore that part of the nation. And the school was great. And you're right. Out here, a lot of people haven't heard of it, I think, because it's a small school, but it is, a good school, like you say, and people on the East Coast know it. And I really, encourage people to check it out and at least check out Maine. I mean, it was such a great place to live. There was snow, of course, but we were right by the ocean, so it wasn't too cold. And then I got to work there a few summers, and summers in Maine cannot be beat.
Now, okay, I'll give you that. So let's talk about college for a sec. But first off, yes, I mean, very, very prestigious. Now, did you say thank you to your parents? Because I saw the tuition for this college, and
I mean, we don't want to.
Your dad's a radiologist, so you wouldn't be going there, dude.
I probably should say we are still paying off those loans.
Believe it, Dad.
You are correct, and I'm sure that, not to date ourselves, but I'm sure the tuition has definitely gone way up since I was there, also. But you're right, definitely lucky. Yes.
But so let me ask you this. I mean, I see you as an amazing doctor. Why did you go to a liberal arts college? And for my listeners who are, maybe in college right now, kind of wondering what major they should be, why liberal arts? Why not dorky biology like I did, like all the other good Indian people like me did? Why didn't you do that?
Yeah, excellent question. Well, honestly, my father's a doctor, like I said. My mom was a nurse, and my older two siblings were doctors. So it was sort of in the back of my mind, but I didn't know when I was applying to college, I didn't know for sure that I wanted to be a doctor at that time. I was open to a lot of different things. I mean, I really did like math and science, but I also loved English and art history and psychology. And I just wanted to explore and study a lot of different subjects. So that's why I did that. And it's good for, your listeners and everyone to know that you can do that. You can have these interests and still be a doctor, and there were a lot of other pre-meds. I mean, it wasn't, I'm sure, as many as in your bio school and education, but there were a lot of people who were pre-med at my college who wanted to try other things. And so you're able to go to a small liberal arts college. We had great science and biochemistry, histology, physics, organic chemistry teachers as well. You remember
come
those?
on, man. Every time you say that name, it's got to leave some kind of like gastric ulcer in you when you hear organic chemistry, That's
right. But what's interesting, and from the bio you read earlier that I hadn't included yet, that we'll talk about now, is the first 2 years of college, and then I studied everything, and I did become interested in pre-med. So I was pre-med my first 2 years of college, but then I just really wanted to study abroad. I wanted to study abroad for a semester. And if you did that, as maybe some of your listeners know, it's pretty difficult to do that, get all your pre-meds done, and still graduate in 4 years. So that's when I decided I wasn't going to graduate with all my pre-med requirements. I ended up studying abroad. I studied abroad in London, and it was fabulous. I was there for a semester, UCL, University College London. I studied art history and psychology. And then I did the classic, American backpacking Eurail trip throughout Europe the summer after. And my little brother is a year below me in school, so he was studying abroad the next semester. So we overlapped in the summer, and we traveled Europe for summer, and it was such a great experience. And I encourage, anyone who can do that. It's just really an amazing experience to travel the world and meet people from all different backgrounds. And during that, we went to Switzerland, and I fell in love with Switzerland. I just loved it. It's a beautiful country. I like the mountains. They have the French-speaking part, the German-speaking part, the Italian-speaking part. So during that trip, I really fell in love with Switzerland. So then I went back to college, and I finished my senior year. I graduated with my major was psychology. And then I found an ad in our career center. Another great thing about small liberal arts is you get to know everyone, they get to know you, and people knew I was looking for a job abroad. There was an ad in our career center. Anyone with experience in admissions, do you want to come work in an American boarding school in Switzerland? And that was exactly where I wanted to be. And I was, I did the interviews for college and the tours for interested students. So I moved to Switzerland, Dr. Raj, and I lived there for 3 years. And
shut the front door. Wait a minute, wait. Just stop for a second. So let me get this straight. So you didn't take the MCATs. You're like, you started liberal arts, you graduated psychology, you know what I mean? You dabbled in pre-med. Yeah. So, I mean, I got to tell you, I love your free spirit. I feel like you're not even going to stay at USC that long. We're like another stepping stone in your or notch in your belt for around the world.
Yeah, I'm hoping a lot of your listeners can relate. I mean,
that's awesome, man.
I was able to be pre-med. It's just I wasn't ready yet. I wanted to sort of experience other things. And it was great. I lived at an American boarding school in Switzerland. I worked
for 3 years.
For 3 years. It was only supposed to be for a year, but I loved it so much and it worked out. And they asked me to stay, so I stayed.
Okay.
I worked in the admissions office. That was such an amazing experience, Raj. So it was an American boarding school, high school, so grades 9 through 12.
Okay.
And just like the curriculum we have here, but it was in Switzerland. And about a third of the students were American expats living abroad.
Sure.
And they wanted their kids to go to a U.S. high school. And then the rest of the students were from about 40 different countries, Africa, Asia, Egypt, Saudi Arabia, Eastern Europe, Western Europe, all over the place, South America. And it was, again, amazing just to learn about other cultures, live with students from all over the world, meet their parents. And when they came to tour, it was such a great experience. And the whole goal was these students wanted to have a U.S. high school diploma because it is a bit easier to get into university in the States, which was their ultimate goal.
Okay.
If you don't need it, but it's easier to get into university in the States if you have a U.S. diploma. So
Gotcha.
That was the point. And it was so great. I mean, I lived at the school, I ate at the school. So any money I made, in addition, after my work, was to travel. So I was at the pyramids in Egypt, New Year's Eve 2000.
Wow.
And
the reason that's cool.
So the reason I wanted to bring it up is these experiences have really helped me become an excellent physician. I mean, I'm able, you and I get along well. I'm sure you've had a lot of great experiences, I can tell too, because these experiences help you get along with everybody, people from all backgrounds. It really helps me with my patients. I know a little Spanish, a little French, a little German, not great, but when and you try, it really helps the physician-patient relationship, and they feel more comfortable, knowing that you have a bit of an idea maybe of where they're coming from. So it was a great experience. And then probably what you're going to ask me is, how did I end up here after all?
There's so many parts to your story. Let me just say one thing, then we'll talk about your stop in Philadelphia, which is going to be med school. But no, I agree with you. I think that for my listeners, I do echo what, Dr. Lin said, which is, being a great doctor is not about what you can memorize and how you can regurgitate information. It really is connecting with people. And I think that you're right. I think me and you are good buds because we've experienced so much. We just know how to relate and just be cool to each other. You know what I mean?
Right.
And that is a skill. Exactly. You don't take a class to do that. You don't get graded on it. So really, that was an awesome tip, dude. But, you decided like, hey, maybe I should take the MCAT. Maybe I shouldn't be like the rogue daughter or son, and not go to med school. So you're in med school now. You're in Jefferson, or really another prestigious place. You know what I mean? Yep. What was your best memory of med school, and what was the hardest part of med school that you could tell my listeners about that maybe you could do over, or maybe you could warn people about?
Yeah, great. So my 360 is, I knew I was interested in medicine overall. So I wanted to come back to the States. I did a post-bac program then, Bryn Mawr, Pennsylvania. That's another small liberal arts school. Mm-hmm. And that's where I finished all my pre-med. So that was a year course, highly recommended. It was great. And that's when then I took my MCAT. And since it was so close to Philly, that's how I ended up then at Jefferson Medical College in Philadelphia. It has since changed its name to Sidney Kimmel Medical Center.
Oh, I mean,
just in the past,
my comment, I didn't even know that.
Yeah, just in the past few years, how can you change the name of a founding father? I don't know, but donors. So
like, what the hell is going on here?
Yeah, so some of your listeners may be there or know of it by that name. So then that's how I ended up in Philly. So probably to answer your question, the hardest part was really making this change of living abroad and living in Europe to coming back and in 1 year finishing all my pre-meds. I mean, I had courses and labs every day and taking the MCAT, all in 1 year. So it was a bit of a lifestyle change, but I knew that's what I wanted to do. And there were a lot of like-minded people at these programs. So if anyone else is listening, interested, I highly recommend it because you can have these other experiences that'll help you in your future. Then you come back with people who've done other things and then all of a sudden very focused and trying to finish their pre-med. So it was a hard year, but a great experience. And then Jefferson Medical School in Philly was great. Now that I'm in Los Angeles, it was very different. It is one of the first medical schools in the country. It's very traditional. There were definitely no jeans or, Birkenstock wearing. I'm not saying we wear Birkenstocks now, but I do see some jeans here and there. But, Jefferson was definitely a tie and, shirt and tie type of place. It was great. I mean, living in one of the oldest cities in America, another city that I hadn't experienced yet, and meeting students from everywhere. I was a bit older than everybody because of what we've talked about, but it was really great. And the advice I have, I think, from what you've heard so far, is it's okay to explore your interests before you get to med school. And if anything, it really helped me focus. By the time I was at med school, I knew this is what I wanted to do.
No, let me just, before you answer more, for the admissions part of it, did it help you that you took a break from college before going to med school? Because, when I do a lot of, how to get the residency you want, talks to people, I'm always like, don't take big breaks. You know what I mean? Knock out your exams in order. So did the admissions committee to many med schools like that part of your resume, CV?
They did. And I think they really did. And now I'm actually an interviewer here at USC, and I love it when I hear that people had these other experiences. Because the people who are applying to med school, everyone's smart, right? And everyone can do the work.
They are.
And they're all passionate. But nowadays, I think schools are, interested and looking for someone who has tried something different, just to bring kind of a different perspective. So I know what you're saying. Schools are always going to ask why you have this break.
Where's this gap?
Right. They're going to ask why. But if you have a reason, such as I did, or an awesome experience that you had, they love to hear it. And it actually makes you stand out, which is great. Yeah.
No, totally. So answer me. Answer this. So in med school, what was your hardest subject? What did you kind of stink at? You had to stink at something. Let's be honest. What was the hardest one for you in med school?
Probably biochemistry, I think.
All right. At least you're honest now. I like that.
Yeah.
Biochemistry is a toughie. You have to know all these enzymes. Is it pyruvate dehydrogenase? Was that the Krebs cycle? I don't know.
Exactly. And I know you're an excellent teacher of it. And I think, because, you get into the details. A lot of the words sound the same. And it's a lot of memorization. Yeah. So I think that was probably my hardest. And what I really enjoyed were the clinical rotations. Right?
Yeah.
That's where your personality shines through, where you have the difficult, and rewarding experiences with the patients. So I think the clinical rotations were my favorite by far.
This is a good setup for my next question. This is good. So, you're extroverted, you can't stay in one place, and you just finished med school and you got to pick the residency. So why does Dr. Lin pick a residency that makes you sit in a dark room the rest of your life? Can you please answer that?
Excellent question that I have asked myself as well. Yeah, very good question. I really enjoyed a lot, almost everything in medical school. I've really enjoyed family med because I really enjoyed patients of all ages, right? I love kids. I really love older adults as well. I grew up with all of my grandparents. And so that's one thing I really loved. Okay. I really loved OB-GYN. I love delivering babies. I just thought it was so fun. And it's really a happy specialty because everyone's, for the most part, so happy, their baby comes.
When the baby is delivered safely, yeah.
How could you not? Yeah, exactly. I know what you're saying. Yeah, there are challenges sometimes, but overall, it was just such a rewarding experience. And so the very good question, I think, and the thing that helped me a lot is that my father was a radiologist, and he always loved his job. I knew about radiology because of him. I used to go to his office. I still remember he always had Oreos in his drawers, I can picture the office. I remember getting, lost in the elevator once. But honestly, as a lot of your listeners will probably relate to, we don't have a lot of experience, a lot of exposure to radiology as a med student. So honestly, without having a family member, as a radiologist, it may have been different, honestly. But the reason why is he just loved his job so much. I'd never met anyone who was so happy to go to work every day.
That's cool.
Wasn't complaining. He really was passionate about it. He did research. I met a lot of his colleagues. They would come over for dinner. So I think that's what fired me up about it. And the good thing about radiology And I definitely want your listeners to know this because we are always looking to recruit more radiologists and more diverse in backgrounds and personality radiologists. Radiology really is no longer, the darkroom basement, Now in our practice at USC, we also do procedures. So that's how I still am able to see patients. I do CT guided lung biopsies and drainages, like you mentioned. So I really enjoy it because I always loved anatomy. That was my favorite course.
It had to be in med school.
First
you guys
year.
are kick butt in anatomy, dude.
Yeah, it was difficult, but I was always fascinated by it. And radiology obviously is a lot of anatomy. I have to say I did like physics as well. So that is what,
Right.
a lot of physics in radiology.
There is.
I did my residency I met my husband in Philly, and then he's from Los Angeles. So that's how we ended up here in Los Angeles. And really, as soon as I came to USC, and I'm interested in your thoughts on this too, I just knew I wanted to stay. The people were, relatively young. In radiology, it kind of, people stay a long time, right? And so tends to be, older. And so that was some of my experience in radiology was, a little bit older. But then you come to USC and everyone is fairly young. Everyone is really enthusiastic and they're fun and nice, like you and I, if we do say so ourselves. And I just knew it just fit with my personality right away. So I know what you're saying, radiology kind of has this reputation, but it's really changing. And now, our department, we relatively have a lot of female residents and faculty compared to a lot of radiology departments. And, it's still not 50-50. I wish it were. And so that's why I'm going to try to, hopefully recruit some people talking to you. But it is really a step in the right direction. So I'm still able to teach and talk. That helps with my personality. And I love the subject matter. And I always loved the lungs. It was actually between this and pulmonary, believe it or not. We would have been colleagues either way.
I could see us giving knuckles to each other being fellow pulmonologists. I think you've been a great pulmonologist, But so when radiology in itself, even though that's the first step, you got to pick your residency, you pick internal medicine or OB-GYN or surgery, but radiology is very, very broad. So of all the different body parts, MSK, the central nervous system, did you have this underlying passion for lung and heart? More lung? Mm-hmm. Was it because of your dad? Was your dad kind of a lung guy?
It was. He was. I do the exact same thing he does. He was also a thoracic radiologist. And so I think that's sort of what... that's just what I knew. So the very first thing I was thinking in radiology residency was always that I would go into chest radiology, because that's what I knew, but I was open, like you say, there's so many fields within fellowships and specialties within radiology. You can do pediatric, neuro, MSK, abdomen, breast, women's imaging, there's an interventional, there's so many different things. And so chest is originally what, because of my dad, but also in med school, I really did love the respiratory course. I just love the lungs because there's all the different infections really fascinated me. I loved how multidisciplinary it was. A lot of, specialties in radiology are, but especially, I remember my dad would always work closely with pathologists and oncologists and surgeons. And I think it really is the pathophys that ultimately is what made my decision. And then coming to USC, the fellowship, cardiothoracic fellowship, we do both diagnostic, reading CTs and x-rays, but it's also half interventional. So that's, that's pretty unique. Not all of chest fellowships, you also do procedures. Some you do, but not all. So that's really what interested me.
So on that note, so are you like the favorite son, daughter of the family? Your dad must love you. I made the spitting image who, I could pass the baton to. Chest radiologist. So does he give you the biggest hug in the whole world when you see him all the time?
Honestly, I think it was a bit of a shock because you heard, okay. Well, just because of my circuitous course of getting here, I don't think he pinned me down as the one who was going to end up doing exactly what he did when I was gallivanting in Europe at the Tour de France, So I think he is very proud. I know that for sure. And he and I go to the Society of Thoracic Radiology meetings together. How cute is this?
That is so awesome.
He's now retired, but he comes to the meeting and he listens to me give talks. And we made it in the newsletter once. I don't think there's been that many father-daughter pairs. And he's actually one of the founding members of the Society of Thoracic Radiology. So they like to have him there. And it's just been really great, an added bonus to the career. But there are 4 of us kids, so I definitely can't say I'm the favorite.
Well, let me just tell you on a little side note. So, my mom and dad, they're retired. My mom's a nurse. My dad's not in medicine. And they used to travel the country to watch me lecture for like Kaplan and other things. I got your back. It's the best feeling in the whole world. Right. You look out in the audience and you see your folks there. It's something that's really, really, really special. Yeah. But let me talk about interventional. So, after all the training, you know what I mean? Did you not feel complete just by looking at films? Did you have to stick needles in people? What was that feeling? You're like, you know what? I just can't only look at images. What promoted you? What encouraged you to go into interventional radiology?
Yeah, I like the challenge, I guess. I think number one, within radiology, once I decided between radiology and pulmonary, medicine, so I decided radiology. Then, you're right. Within radiology, how did I decide? So I told you how I got interested in chest, but with my personality, I realized I needed to do procedures because that's how I was able to see patients. In med school, the clinical rotations, like I talked about, I just really love that patient, physician relationship. It's just a real special thing, right? Trying to help people, make them feel comfortable and ease their anxiety, especially when they're coming to me for procedures. So within radiology residency, I really enjoyed the intervention, doing the procedures because I could see patients. I also really enjoyed women's imaging. I know we'll talk a little bit about women in medicine also, but also because there are a lot of procedures. There's a lot of biopsies, involved with breast biopsies and breast imaging. So I think the main reason is that's how I was able to see patients and, talk basically at work. But also I do love the challenge. I've always liked to work with my hands. And honestly, our fellowship directors and chest radiology staff here were such great teachers that they really made me enjoy doing the lung biopsies. They can be scary because a risk is a collapsed lung. Obviously, you know that. So it takes a lot of skill, but I just enjoy it mostly to see the patients and then really just the satisfaction of helping them get a diagnosis to help move their treatment forward.
And I got to tell you, personally speaking, being a pulmonologist, I love all you guys and gals in interventional because, when I'm having these consults and the issue is tissue and I'm like, dude, I can't get this. You know what? Let's call interventional radiology. Let them help us out. And it's so nice to have colleagues that could get those places in the lung that are not that safe and help us out. So you guys and gals are awesome.
We're definitely a good team between our 2 departments. Yeah.
So, hey, let me go into, so I got some, I wanted to switch the gears on this conversation to a very important topic, which is lung cancer screening. Yeah. And, I actually touched base with some of the medical students that followed the podcast. Thank you very much. And they asked some questions because I said we're going to have an awesome interventional radiologist here. So here are some lung cancer screening. And I think this is important, because lung cancer screening, tends to go under the radar sometimes, rightly so. Breast, cervical, colon always seems to take the medal stand for the gold, silver, and bronze. And people forget we do screen for lung cancer in the United States. So my first question is, and these are going to be questions that students gave to me. So what is lung cancer screening and how do we do it?
Excellent. So that is an excellent question. So another answer to your question of why I chose chest when I was in residency is lung cancer screening started while I was a resident. So that was another very hot topic, so it's been almost 10 years that it's been around. So what is it? Okay. So lung cancer is by far the leading cause of cancer death among both men and women, and it makes up about 25% of all cancer deaths. It's a really bad diagnosis. Yes. And this was interesting for me to learn, but each year more people die of lung lung cancer than of colon, breast, and prostate cancers combined. I mean, think of that. Probably, unfortunately, a lot of us know someone who has colon, breast, or prostate, and just think, lung is even more common than that. And plus, it's very deadly. It's a very serious cancer. So, we as physicians, we screen for those other 3 cancers that I mentioned. We do fecal occult blood tests for colon cancer. Mammograms are fairly easy and inexpensive ways to screen for breast cancer. And then prostate cancer, we have a blood test, right, that we can screen. So those are pretty easy to screen for. But the problem with lung is it's a bit more difficult to screen for lung cancer, which is, I think, why it took so long for it to come around. Because the way we screen for lung cancer is we have to do it by CT. Okay, so to find these really small nodules, you can get chest X-rays. Our listeners know about chest X-rays, but really small, a lot of small lung nodules you just can't see by X-ray. So really the biggest screening tool for lung cancer screening is CT. Well, the problem with that is CTs are much more expensive, right, than blood tests or, fecal occult tests and even mammograms. CTs are a lot more expensive than, the X-rays that the mammograms are. So that's why, so I told you why we're doing it in terms of the risk factors, why it's a need, within our population. And then the reason of the delay was probably to get, insurance companies and everybody behind paying for CTs for these patients.
Well, let me ask you this. I mean, when we ask you how we do it, so you may have answered it because, in medical school, when you teach residents and interns, imaging the lung, we always why not a chest X-ray? You know what I mean?
Right.
Shortness of breath, I say chest X-ray. You know what I mean?
You always start with a chest X-ray. Yeah.
Even you, thanks for getting my back on that. So my question is, was it just not detailed enough getting a chest X-ray? Because you're focusing on, yes, expense, but radiation too by screening with a CT. Yeah. So what was the main reason why we chose CT? Was it because it just picks up, it's more sensitive if I'm using the right word?
It can pick up smaller nodules. You're right, Dr. Raj. For any chest pathology, you should always start with a chest X-ray. And we definitely believe that, in chest radiology as well, right? Because that's the way you can tell. If someone is short of breath, it could be many things. It could be fluid on the lungs. It could be infection. So you should always start with a chest X-ray because it's easy, fast, and not a lot of radiation. So that's an excellent point. But the reason the screening has to be CT, and there were, huge national lung cancer screening trials that started about 10 years ago. And a lot of studies have looked at X-ray versus CT, and they found, using data that CTs really do pick up smaller cancerous nodules faster and more easily than X-ray. So there were big studies on this. So you're right, radiation is an issue, which is, not only are CTs expensive, but they're also more radiation. But that's why they did these big studies to show why the CTs are needed. And it's because they pick up these small cancers that X-rays cannot. So then now what we do is we came up with a low dose CT protocol. So what that means is for lung cancer screening, we give a little bit less radiation for these CTs. So why don't we do that with everybody? Well,
why did you read my mind? Why don't we just do that? Just always click low dose for everything then.
Yeah, and the reason for that is because it doesn't pick up the soft tissues very well. And by that I mean like lymph nodes, or if you have an aneurysm of your aorta or a lymph node, if that's what you're worried about for a patient, you need to get a regular CT because you can see soft tissues better. Okay. But if you're just looking at the lungs, and as we all know, lungs are mostly air, you don't need a lot of radiation to pick up nodules. So now, after all this, the American Cancer Society recommends annual lung cancer screening with a low dose CT scan, which we have here and almost, all hospitals do now, for certain people at higher risk for lung cancer who meet the following conditions. And I'll go over that with you. So we do low dose CT, so we try to give as low dose as possible. And And then we only screen high risk people. And this is true, for like colon cancer as well. You start at a certain age. It's not that you start, it's not that you screen everybody. So the reason we choose the high risk people again is because of, radiation. You don't want to start, screening at age 10, right? Because then these patients are going to be getting a lot of radiation. But also studies have been shown, around what age should you start screening. So after all these national lung cancer screening trials, which you can look up, the NLSTs, what we decided is we're going to scan these patients with low-dose CT scans and see if they qualify. So you qualify if you're age 55 to 74 years old.
Now, is it now? I gotta step it up a little bit. Now, is it 74 or is it 79?
Okay, so very good question.
I don't want to be that weird host that's putting the guest on the spot. But can you? I didn't know what changed.
No, you're right. So the U.S. Preventative Services Task Force. So what Dr. Raj is saying, we used to screen up to age 74, but right now, we're in progress by the U.S. Preventative Services Task Force to up the age limit. You're right, because 74, that's pretty young. 74 is the new 54, right? So so not only that, but really there's been studies to show that we should screen longer. So actually, you're right. I'm going to mention the most recent. They're not totally fully accepted yet. They're in process of being accepted, but it's low-dose CT now, the newest ones in progress. In adults age 50 to 80 who have a 20-pack year smoking history, who currently smoke or who have quit within the past 15 years. Gotcha. So that's important. So even though patients have quit, you should still, if they have this 20-pack year smoking history, which is a lot of high amount of smoking, you should still screen them even if they've quit within the past 15 years. And that's it. Then screening should be discontinued once a person has not smoked for more than 15 years or develops a health problem that limits life expectancy, or they're going to be getting some other sort of follow-up for something else. So then we stop screening. But really what you should remember
I love this banter. Or I'm going to throw one more in there.
Okay, yeah.
Is, in broad strokes, you know what I mean? The key thing about these lung cancers, you want to have a stage that's a lower stage. You know what I mean? When I mean lower staging, that something where you can go for cure, and cure is going to be surgery most of the time. So if you're not a surgical candidate, wouldn't it be reasonable to say maybe we will stop screening if you're not going to accept surgery or can't go through surgery? Is that too mean of a statement, or does it make sense?
No. So I know what you're saying. Why screen if you're not going to be able to go surgery? Well, the good thing is now, and especially here at USC, is there's a lot of advancements in chemo and also radiation therapy. So even if they aren't good surgical candidates, there's more treatments for these patients as well. So we do this at USC, that if they can't have surgery, well, at least we can radiate this area.
All right, I can buy that.
So that's why we're sticking to it for now. But yeah, that's a good point.
So here's another great question. So, you already stole the last question, which was who should be screened. So we're going to go to the next one. So you're just on your A game today. So one of the medical students asked, for lung cancer screening, does it matter if the patient has symptoms? So I kind of like that, because I guess if they're coughing, he wasn't specific about what symptoms, or if they have weight loss. Does that change what we're doing or no?
Yes. Yeah, that's a very good question, because it comes up all the time. Very, very good question. So it is written in the literature that, if the patient has symptoms, then that's not necessarily lung cancer screening. They don't necessarily qualify. So you're right. It depends what they mean by symptoms. And the reason for that is if they have symptoms, and usually that means, cough or extreme shortness of breath, or, coughing up blood, maybe something like that. Yeah. The reason why what we're saying is then those people should probably get a regular CT, and probably one with intravenous contrast, which is a whole other story. But the reason, if they have symptoms, they should get probably a little bit more detailed study, because there might be something else going on, right? It might be another type of pneumonia or some other problem that you need a little more in-depth evaluation. But the thing is sometimes it's difficult because a lot of patients who smoke, this much, it's so much that they qualify for lung cancer screening, sort of have chronic symptoms, so,
like the cough,
sort of have this little
bronchitis, you know what I mean?
Yeah, exactly. Like a mild chronic cough. So it's a very good question. I think the question is what type of symptoms. If they have, chronic cough for 10 years, well, yeah, those people still qualify for lung cancer screening because it's kind of their baseline. But if they have some new symptom, like coughing up blood or something like that, then we wouldn't necessarily do a screening study. We'd do a more detailed full CT on those patients.
So here's a tough one. I mean, I'm trying to trying to get the answer before reading it out loud to you. So that student, I guess probably did their studying about what screening was. So the question is, I have a patient who's one of the high risk groups. I guess, the risk factors that you were talking about, but have been diagnosed with a cancer in the past. Is low dose CT lung cancer screening still the right answer for those patients?
Yeah, that's a very good question. So usually typical lung cancer screening is not, if they have a prior cancer, they don't necessarily qualify. And the reason for that is usually that those patients are undergoing some other type of follow-up according to that type of cancer. Do you see what I mean? So
yeah, so that was a good question.
It was, yeah.
Right.
That was a great question.
Right there, okay.
Yeah, because what I'm trying to say is, it depends what type of cancer that patient has, but let's say that patient had, colon cancer. Sure. Well, they're probably, they probably get, depending on, what the stage was and what happens, they're probably getting follow-up scans anyway, because they look for metastases in the lungs for different types of cancer. So usually patients who have cancer in the past are still on some type of follow-up, imaging for that particular cancer. So then we don't want to do double,
that makes sense.
Yeah, because we can pick
100% sense.
Yeah. So that was a great question. It comes up all the time.
I want to give that, you know what? I didn't write down all the names of who sent in the stuff. That's worthy of getting like a free book or something right there. That was a good question.
Yeah, that student's thinking.
Yeah. So here's a good one. And you didn't answer it yet. So for lung cancer screening, do they have to get a screening exam every year?
Yep. It's every year. And up until age 80 is what, the new guidelines are saying. And, so I am the director of the lung cancer screening program here at USC. Okay. And we have a great research team and they, we have a great database that they keep track of. So they will contact the patients every year. It's hard, right? I mean,
it's super hard.
Yeah. Again, and it's hard for patients, again, CTs are not as easy as some of those other screening tests for other cancers, so, sometimes patients won't show up every year exactly when they, to the day, but, as long as we can get them back, at least within the month or two or get them at all, it's great. And we have picked up a lot of we've been doing this for maybe about 5 years. We've picked up about 11 to 12 lung cancers. I know that doesn't sound like a lot, but that's actually, pretty in line with the national findings. But what's really interesting, it's another thing we haven't even talked about yet, is even though those are the lung cancers we picked up, but the good thing is we picked them up in an early stage and they were able to get surgery or radiation or chemo like we talked about and are doing, great. So that's a great thing about screening is you pick it up at an earlier stage. And that's why CT is probably, is better than X-ray like we talked about. But the thing is what we haven't talked about yet is the thing about CT is you're getting a whole evaluation of the chest and the upper part of the abdomen because kind of the diaphragms are a little domed. So we've actually picked up even more incidental cancers, believe it or not, like adrenal gland cancers or maybe renal cancers. So this is why we want to do it every year and we keep track of all of our patients and we've really helped people. Yeah.
No, and this is kind of a good segue to the last couple of questions, which on this topic, which is going to be, so how effective is low-dose CT at preventing death from lung cancer? So I think they're looking for some number crunching. So you were kind of talking about, this is how many we discovered over the last, year at USC. So that's consistent with the national data. So what are we expecting numbers wise, in preventing death by doing this?
So this is a very, very great question and has been studied, in all these past studies. So here are the details. So early detection by low dose screening can decrease lung cancer mortality by 14 to 20% among high-risk populations. So what does that mean in numbers? So here's what it means in numbers. About 8 million of Americans qualify as high risk for lung cancer and are recommended to receive the annual screening. So of all those guidelines I told you about, pack year, smoking history, and age, we have about 8 million Americans, in all of America who qualify. And so, are all those patients going to get scanned? I mean, we want them to, right? But probably not, right? Transportation is an issue, insurance might be an issue, and, motivation of wanting to get screened. But listen, let's say we screened half of those 8 million, so half of the people who qualify, if half of these high-risk individuals were screened, over 12,000 lung cancer deaths could be prevented.
Oh, wow.
Isn't that amazing? So I hope that answers the question, but they're asking, what is the impact? The impact is really high because smoking is really prevalent, as we all know, in our country. And this is a real need. So actually, where are we now about 10 years since lung cancer screening has started? We're doing great. We're picking up lower stage. We are really saving people's lives and, extending their lives. But what is the real issue now? The real issue now is trying to target these 8 million Americans who qualify. Some people just don't even know about screening. I mean, that's why I'm so glad you're asking me this.
No, definitely.
So really our goal now in 2021 is to really spread the message about who needs to be screened and how you can do it, and that it's even out there, because
so it's really raising that awareness in the public sense. No, that's awesome. So I'm going to ask you 2 more questions about this, but just to throw a little side note in there, and I don't know, I think you know this, but my dad was diagnosed with lung cancer. He never smoked, and he had what you guys refer to as adenocarcinoma in situ.
Yep.
And it was discovered because he has CLL, chronic lymphocytic leukemia. They were going to check out some lymph nodes or something for a totally other reason. And they found it like an oops incidentaloma. Yep. And because it was such an early stage, they pushed the lobectomy and it got out there. And everything you just said makes sense. Finding incidental cancers and finding it at an early stage, and it does save lives. So that's amazing.
Yep, I remember meeting them in the student remember, I sat with you guys. And we had lunch. He was there for one of his appointments. They're so sweet.
Yes. Yeah. So the last question, or second to last, would be, with this is one of my questions, which is, with anything, there's always going to be risks. And I know that there are some risks when you do talk about lung cancer screening. And I can tell you what I think, but what are some of the risks that you inform your patients before agreeing to do this?
Very good. So radiation is a risk, right?
Yep.
There have been, no definite studies to show like radiation from CTs causes cancer, right? We all know radiation is dangerous from, catastrophes like Chernobyl and things that have happened. But luckily, we are able now with our, high tech and the advances we've made in our CT scanners to really get the dose really, really low, the radiation dose. So I really think the benefits of lung cancer screening outweigh the low, theoretical risk of radiation, and our low dose is really low. It's true when we say low dose. So if it were my family member or myself, I would definitely recommend them do it, and that not to be worried about that radiation part of it. But there are other risks too. That you're talking about. And honestly, the biggest risk is finding incidental findings that may or may not have caused a problem, right? We all know that, you can find many adrenal nodules are benign, right? Yeah. But now the poor patient has to go through this full workup. They may have never known they had it and they would have done fine and nothing. Yeah. But now let's say they undergo a biopsy and they get a complication from a biopsy and it's a benign lesion. So they didn't even need the biopsy. So I think that even though CT is great because you can really see a lot. That's one of the risks. You can really see a lot and you might find stuff that wouldn't have otherwise caused a problem. So we're really dealing with that with just, continuing to decrease, radiation dose, make sure we screen the right people, and just, a lot of research studies are happening now about all these incidental findings. We're actually part of a large MD Anderson study, and I input every single CT we do, we input all the findings. And so there's studies going on now about how many of these, benign incidental tumors of other organs, what's the impact? Like, does it really matter? How many people are we saving? How many people are we hurting by doing unnecessary biopsies for benign things? Yep. So it's a very good point. So
I'm glad you brought it up. And I think it's the anxiety issue. And I think that I have these people in my lung clinic, the pulmonary clinic, where they just want that CT. And that when you order the CT, because they'll kind of bully me into it because I'm a nice guy, I won't make the diagnosis I want, but we'll find an oops, I saw a nodule. And now the frown on their face, the tears that are coming out, Yeah. So I'm glad you brought that one up. Now, here's my last question, and then we have to get to a couple more things because we're almost dude, we are like the most chatty people. It's almost been an hour already. It's crazy.
Yeah, no problem. Okay. Yep.
But so after they do their low dose CT screen, what can they expect on the results? Just explain to me. So they got the test. Let's say something's positive. What happens? Do you call them up? What is the next steps for them?
Yep, very good. Yep. So our research team will send a letter to the ordering doctor. So usually the patient's primary care doctor has ordered this study. Mm-hmm. So our team will send a letter to the doctor, and if they aren't able to get a hold of the doctor, they'll send the letter to the patient. And what lung cancer screening does is we give a score called lung RADS, lung-RADS, RADS, and it gives, a scoring system. And if you get a lung RADS 1, that means you have no lung nodules at all in your lungs. Yay. If you get a lung RADS 2, it means you have a benign or small nodule. So 6 millimeters or less is a lung RADS 2. And those, based on all the data of all the studies we've done in the past 10 years, nodules less than 6 millimeters are really, usually benign. And if they aren't benign, they're so small and slow growing that it's okay to follow those once a year. So if you get a lung RADS 2, it means you have a nodule less than 6 millimeters and we'll follow you in a year. If we have a lung RADS 3, that means a nodule 6 to 8 millimeters. So if the patient has a nodule that's 6 to 8 millimeters on their scan, we'll call them back in 6 months. So instead of 12 months, it's 6 months. And the reason for that is, it's a kind of a big nodule, but still there's a lot of benign, even benign pulmonary nodules, like you mentioned. Mm-hmm. And so if it hasn't grown in 6 months, then we're less worried. If it's a nodule greater than a centimeter, that's when we worry. We call it a lung RADS 4, and that's when we call the patients in for further workup. And that can either be a PET CT, which is another type of study to help us decide if it's malignant or not, or the patient will get a biopsy.
Yeah. And I know for us, we used to do this together. There's like a tumor board where we all meet down and we kind of argue in a nice way. What's the safest, best way? What's the next best step in the management of this patient? Because it's very individualized and there's not one plan that fits all patients. So I think that's also important just to throw it out there.
Yep.
Now, let me ask you that I threw a last minute Raj question. So in your experience doing so much, the lung cancer screening, for the smokers out there, do most of your patients who smoke stop after they get the negative screen?
So that's a very good question. I
gotta know.
Yeah, I have to say I don't really know that, because I'm seeing their scans, but I think the question to ask would be their primary doctors who follow them up. But one way that I can tell, Dr. Raj, is we we give a questionnaire before every screener, just to see how many pack years, and maybe patients have new risk factors as the year goes on, And I have to say, I do often see the numbers of smokers go down. I do, if they haven't quit totally, they have decreased at least. So I think it just depends. Some people don't stop. Some people stop cold turkey, and some people decrease. But to your question, I'd have to say another part of our program that I didn't mention earlier is lung cancer. Excuse me, smoking cessation.
Has to be.
So we talk to the doctors and also give the patients resources for smoking cessation. So we really try to do a full, picture, not just the CT, but give them other tools.
What scares me the most is like the person who gets the results. It's negative. It's a benign study, and they're like, yes, another year of smoke. That's what I don't want. So I think it's great that you have, a part of your program that really focuses on, okay, man, you got to pass, but you got to stop. And here's the steps, and here's the tools to help you stop. I think that's important. So I want to make sure we talk about something else, because we're like oh my God, it's been longer than I thought. I'm going to talk about breast cancer screening another time. I know that it's super passionate about you, but I wanted to close up talking about women in medicine, women in radiology, and just kind of ask you in general. I mean, when I was reading your CV, I don't know if everyone picked up on it, but that's one of your passions is about women in medicine and radiology. How did that become a passion for you? And can you also maybe just go into what can you do if you're a woman in med school and deciding where to go and why to go into radiology?
I'm so glad that you asked me this because it is a passion of mine. So how I became interested is, it really ties into a lot of the stuff I've always talked about is I really am passionate about medicine in general, but I'm not maybe the most, I didn't take the most typical course, right? I studied something else, I lived abroad, and then I decided to go into medicine. So I really wanted to get the message across to people in general that you can, follow your passions and be your authentic self and still be a doctor and still be a great doctor. You don't have to go through the same path that everybody else does, step, one by one. And I think it helps us become, excellent physicians, like I already said. So that being said, I feel like my path is unique, but also women in medicine and women leaders in medicine are still lacking, right? If you look in academic centers, you have assistant professors, associate professors, and professors, and but you get promoted based on your scholarly activity. There's a bunch of things tied into it. Exactly. Well, if you look, there's very few women full professors, right?
Okay.
Very few. And it can't be because there's no women, right? I mean, of course, we all know in med school, there's almost, even more than half women. So where do they all go? So this is what kind of sparked my interest in it. And we're all here, but what really happens is, women have a lot of other duties too, right? Whether you start a family or whatever, there's a lot of data showing that women do a lot more of the homework in terms of hours than guys do. Yes. Yeah, even if both spouses are working, right? So there's a lot of data, so the reason I'm passionate about it is I think women leaders are needed. It helps to have multiple leadership styles, and it helps to create a nice, diverse atmosphere in leadership because we have a diverse physician pool, right? So we need this to be reflected in our leadership. And so not only do I feel like I can use my skills based on my background, but also I'm really passionate about just letting people know that you can still be your authentic self and a woman and succeed in medicine. And how this helped is I started to meet other people like me, right? I started to go to conferences. So I want to, let your women listeners know, and the men too as well. There's a big he for she movement going on in medicine too, of how men can support their women colleagues. But really what happened for me is I attended 2 women in leadership conferences. One is called the Career Advancement and Leadership Skills for Women in Healthcare, run by Harvard Medical School. And the other is Women in Medicine Summit, that is given by the University of Illinois. And this was really great because it gave a lot of courses about leadership style, motivation, negotiation, mentorship, and just, giving the women the tools they need to succeed. Because traditionally, the males were given these tools just because there are a lot more male role models. So I'm just real passionate about becoming a role model for women to show that you can do all of these things and succeed. So I just want to share my what I've learned at these conferences. So I'm starting a group I'm just starting it small in our department because we have a lot of women residents, fellows, and faculty where we're all going to get together once a month. For now, it's by Zoom. We're going to go over an article, maybe about leadership style, maybe about negotiation, maybe about public speaking, and other practical things too, how to write your bio.
That's
how to network and all of these things. Because I really feel like there are a lot of women out there who would be excellent leaders, but maybe didn't have the tools or don't know where to start. So it's starting out. I recommend these 2 courses for sure. And, in the notes, I'd love to give out my email address, Dr. Raj. And if anyone's interested about learning more or perhaps doing a project together, they can contact me.
Well, say it right now, just in case. I want to say it right now.
Okay. So my email address is leahlin@med.usc.edu. So that's LEAHLIN at med.usc.edu.
Well, hey, I'm not going to let you go without. I am not short of questions. I just want one more, but I really want to dive into, being a woman in radiology and medicine. So my last question, almost last question, is kind of a spicy one, but I think it's worth saying, is that, during your training, med school, internship, residency, fellowships, were your best mentors women? Did other women in your field support you, or did you feel you're always competing with them? Can you comment about that? Because I know that I interviewed other people who sometimes said you think women would be the best mentors for other women, but sometimes it's not like that. Yeah. Any comments about that?
Yeah, that's a great question. I have to say overall, radiology in the past and probably still has been a pretty male dominated field. So, when I started out, med school and residency, most of my mentors, program directors and everything were men, right? Yeah. And they were great. I mean, they were great mentors and they really helped me a lot. But not until I came to USC and I really sort of, alluded to this already. There were so many women. Actually, in my section, the chest division, we have 5 women out of 7. So we're really lucky.
Now you're seeing, and they're all amazing.
And so the answer to that part of the question.
Let's give a shout out to our girl Allison, dude. She's amazing.
Yeah, Dr. Allison Wilcox is.
I love her.
Yeah, she's the chief of Cardiothoracic Imaging, and she's about to become the chief of staff of Keck Hospital. So she has been great mentor. So to answer your question, when I came here, there were so many women mentors, and they have been really helpful and empowering and supportive. And I know what you're saying. It could go either way, but I think that's what I'm trying to start this group and kind of cultivate this culture of amplifying other women, and I notice the people who do it, when you're at a meeting, if a woman has a good idea, mention it, say that's a great idea, and you sort of amplify it. Yeah. And it's just because, it hasn't been tradition in the past, for the women leaders to speak up for whatever reasons. And so now's our time to really start that. And I've noticed in our department and USC in general, I really feel like the women physicians are empowering the other women physicians. So now's the time to grab hold. So that's why I'm starting it. Yep.
Yeah. And, I'm going to put you on the spot again. I kind of asked this question because being critical care, and I interviewed, wonderful women critical care doctors on my podcast. I think in certain fields in medicine, there's kind of like a boys club, and I'm not saying it's wrong. In critical care, there's a lot of men in there, Yep. And I kind of feel in radiology, you said already, there's a lot of men in radiology, Yep. Do you have any tips for women about how to hold yourself in the air quote boys club? Are there certain things you do so you won't get pigeonholed or, to make sure you succeed?
Yeah. Well, I'm glad you say that, because that's the thing I struggled with at the beginning is, do we really have to act like guys to succeed in a male-dominated place? And the answer is no. Everyone thinks that originally, and that's how a lot of us got through. You're right. Med school and all those hard rotations, surgery is a classic one. But I like to think I have, like an outgoing personality, maybe not the typical for even a physician or even a radiologist, right? But yet I have a lot to add. I think it's a good thing, right? Because like I said, I think we really need to diversify our leadership styles. So a lot of these courses I've gone through, we need the guys, right? Because the guys still have the majority of the power, right? At the meetings and the hospital leadership. So really what we need to do, and I'm going to do this with our awesome male residents as well, is we really need a strong he for she movement, right? We need to talk to our guys, because a lot of the guys just don't realize, that, when they show support for their women colleagues, their women colleagues really need that. Even though we all are very independent, you and me, Raj, you may not know, I am very independent, outgoing and hardworking and a leader, but I still need your support at meetings, because the fact of the matter is a lot of people also in administration and leadership listen to the guys, right? So if you and I are in a meeting,
You're right.
And I bring an idea up, it's so helpful for you to be like, yeah, Dr. Lin's right. That's a great idea and we should do it. So I think really pulling our male colleagues in as team members is really going to help all of us just diversify and succeed. And our patients will love it to have a more diverse leadership pool, I think.
No, and I could really see you being a good leader, in general for radiology at USC. I think that's what I admire the most about you. That's why I asked you to be on the podcast, because you're the most human person I know, and I don't have to change anything about my personality when I call you. Remember, I call you on Saturdays because I just want to. I need your help. Because that's the personality you give off, and that's how you become successful, is giving off that personality.
Yep, we're authentic. That's how I feel.
Authentic. Well said.
Exactly.
Well said. So you know what? You kind of set yourself up for me kind of closing with this. We got to talk about breast cancer. Are you going to be willing to come back so we could do another podcast together?
Oh, definitely. This was great. I really appreciate it. And I had fun, of course.
That's awesome. So everyone, thank you for joining the Dr. Raj Show. I have all her information there. Definitely, when she gave her email out, I'll put it definitely on the show notes. She means it. Contact her. She is awesome. Thanks again, Dr. Lin, for everything. And I'll see you around USC soon.
Yes. Thanks, Dr. Raj. I had a great time. Thanks for having me.
You're welcome.
Thanks for listening. This has been a production of Ars Longa Media. Our producers are Madison Linden and Chris Brightigan. Our executive producer is Dr. Patrick Beeman. This podcast is for educational purposes only and not intended for medical advice. Ars Longa, Vita Brevis.